You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. In this episode of The Dish on Health IT, we explore the important relationship between standards development and policymaking, using the CMS 0062 proposed rule as a timely example. Host Tony Schueth, CEO of Point of Care Partners, welcomes Pooja Babbrah, EVP of Strategy and Industry Alignment at NCPDP, and Anna Taylor, MultiCare's Associate Vice President of Population Health and Value-Based Care, and a member of the HL7 Da Vinci Project Steering Committee. Together, they discuss how standards communities help shape the future of interoperability policy, why industry participation matters, and what healthcare organizations should be thinking about as policy, standards, and implementation continue to evolve. We hope you enjoy the discussion. If you have suggestions for future episodes, send us your idea by visiting the podcast page at POCP.com under the Insights section and share your thoughts by submitting a form.
Welcome to The Dish on Health IT. I'm Tony Schueth, CEO of Point of Care Partners, and your host for today's episode. On this show, we serve up fresh perspectives and candid conversations on the challenges and opportunities shaping health IT. Today, we're digging into the relationship between standards development and policymaking, with a specific focus on the recent CMS 0062P interoperability and drug PA proposed rule. Standards communities like NCPDP and the HL7 Da Vinci Project influence the future of healthcare long before requirements appear in federal regulations. Too often, organizations treat standards work as something abstract or optional. In reality, these communities are where operational problems are debated, workflows are tested, implementation realities surface, and the future policy direction often begins to take shape. Today, I'm thrilled to welcome two people who spend a tremendous amount of time in those conversations. We're joined by Pooja Babbrah, EVP of Strategy and Industry Alignment at NCPDP, and Anna Taylor, Associate Vice President of Population Health and Value-Based Care and Steering Committee member of the HL7 Da Vinci Project. Pooja, Anna, thanks for joining us. Before we jump into the discussion, let's start with some introductions. Please introduce yourselves and talk a little bit about your roles within NCPDP and the HL7 Da Vinci Project, respectively. Anna, can you start?
Yeah, absolutely. Thanks for having me and Pooja today, Tony. I'm Anna Taylor. I currently reside at MultiCare Health System, and I am the steering chair for the Da Vinci HL7 Accelerator, which works on the data interchange between payers and providers and how we operate and make it better for our members and our patients. My journey through healthcare has really been, I started as a human factors engineer. I wanted to be a teacher, but healthcare just kept calling and there were lots of problems to solve in healthcare, and I never have stopped learning. So I've been in this discussion for quite some time now and really honored to be a part of it and to be a part of this podcast today. I'm looking forward to having a good, juicy conversation.
We are looking forward to it as well. Pooja, why don't you go next?
Yeah, thanks, Tony. And I'm also really excited to be here with Anna. I'm always a huge fan of all her work. So as you mentioned, I'm the EVP of Strategy and Industry Alignment for NCPDP. I've been in this role a little over a year and a half now. My focus is on moving forward, really our strategic plan that's set by our board of trustees. We're doing a lot of industry initiatives, ensuring pharmacists are represented in, clinical data exchange, things like TEFCA, ensuring NCPDP is at the table during discussions with HHS around, price transparency, EPA, all of that. My background is actually in product management and strategy. And of course, I spent nearly a decade at Point of Care Partners, working alongside with some of the, I think, best minds in health IT. So also thrilled to be here and really looking forward to this conversation. So thanks for having me as a guest.
Well, thanks for joining us. From your perspective, how should the industry think about the relationship between standards development and policymaking today? And for organizations that have never participated in communities like Da Vinci or NCPDP, what would probably surprise them most about how much practical, operational problem solving actually happens in those settings? Pooja, why don't you go first?
Yeah, I think, first of all, I just have to say, I think what the biggest thing that I think would surprise people is really that how dedicated people are trying to solve real world problems, right? We often think of standards as bits and bytes, right? And, but if you actually sit in and listen to the discussion, it's truly people tackling, what's happening in our industry today. I think prior to being on staff, I was a longtime member, I was chair of the board, and we were involved with several task groups and work groups. And, I'll just give one example, right? Specialty prescriptions. So, you're trying to send a specialty medication to a pharmacy, and a lot of times you need clinical information to go along with that, right? And that was a real world problem that we were trying to solve to make it easier for patients to access their prescriptions, right? To get on therapy. We do a lot at NCPDP kind of jointly with HL7. And I think what we recognize is, it's one thing to look at standards and to try to build a standard for something, but you got to zoom back and look at the workflow, right? And what's happening with providers, what's happening with patients. Our biggest thing is to make patients better, right? To improve outcomes. And you really have to look at it from that lens. I would say from a policy perspective, we have a lot of folks across HHS, whether it's, Office of National Coordinator, CMS, FDA, who are attending our task groups or attending our work groups and really work side by side with our members. I remember during COVID, right, there was that emergency declaration that pharmacists could actually do test and treat, right, for COVID. And we had to come up with the ability for pharmacists to be able to bill for that. So I know our members spent hours and hours with CMS and with HHS folks of saying, how are we going to do this? What are the codes? What's how are we going to make sure that the pharmacists are getting reimbursed? How are we going to make sure we're able to do that? That's another example, right, of like what's actually happening in these conversations at the standards development organizations. And just one more example, right now, Medicare is going to cover for or CMS is going to cover for Medicare beneficiaries GLP-1s as long as the diagnosis is diabetes. We've been having these conversations with CMS for the past 6 months of like, in reality, when that Medicare patient shows up at the pharmacy, what is actually going to happen? And CMS is trying to launch this July 1st. I mean, we've had listening session after listening session discussion of like, we got to make sure this is working, right? We don't want patients to show up and be like, hey, you can't get your med. So those are the actual real conversations that are happening today in the standards development organizations. So it's like standards development, business problems, and policy all happening together.
And it's similar within Da Vinci, isn't it?
It is. And I'm always in awe of Pooja and all of her depth of all this. I feel like I've learned so much from you, and I keep learning every time I listen to you. It's similar in Da Vinci. Policy and standards go hand in hand because as an industry, and it's very interesting as we're looking at the marketplace, just in general around artificial intelligence and will it be governed or not governed? It's this big debate, right? And I think the relationship here inside of healthcare and what we're doing with the payer-provider relationship is not waiting for regulation to come. And in a sense, it gives us a space to self-regulate. So these standards community enable us to bring the brightest minds together in order to get to the best outcomes, as Pooja shared, for our patients, for our members, for ourselves, because we're all patients and customers of healthcare. So I think they're really important spaces for people to get involved. And if you're not involved in that conversation, I encourage you, because just as Pooja shared, the ONC, CMS, the National Standards Group are all participating in these conversations. We're working hand in hand to figure out what is the best way, how much regulation do we need and how much do we not need, because we can self-regulate. And those are important conversations because, we can go, the pendulum can swing, both ways, and you would hope somewhere in the middle you get to the best answer that enables us to have innovation, continue the growth, the GDP, all of that, and enables us to do it safely, ethically, and cost effectively in the economic models that exist today. So I think it is really, really important to get involved in that conversation. If you're not already, it is a place where there's lots of influence and on the ink before it dries, if we have to have ink. And then there's also conversation about, oh, well, yeah, this just makes sense. Let's just all do it this way. And nothing feels better than coming together for the good of humans to make something work the right way or the best way for everyone.
Well said. Nothing really. It's really rewarding, isn't it? It's very rewarding.
So rewarding, very rewarding.
So we often hear organizations say that they'll wait for the final rule before they get deeply involved. What do organizations potentially miss by not participating earlier in standards discussions, pilots, connectathons, implementation guide development, and even the federal comment process itself? How important is it for stakeholders to recognize that these conversations collectively help shape not only implementation realities, but also sometimes the direction of future policy and requirements? Pooja, do you want to take the first shot at that?
Yeah, I think it's interesting because at NCPDP we never had a thing called connectathons, right? Like the way we do our standards development is there are like 200 people in the room. We're talking through everything and we finalize a standard. I think there's different ways to do it, right? I think that's worked in the past, but things are moving so quickly now that I think it's really important, first of all, for people to be in the room talking about all this stuff, but also introducing things like piloting and testing. Over this past year, we, again, going back to kind of the policy piece, Office of National Coordinator, ONC, came to NCPDP and said, hey, we're hearing from industry that one of the big problems right now is patients knowing whether their pharmacy is going to have the medication before they actually drive there to pick it up. And so we quickly pulled together a pilot and an implementation guide that we had groups testing to say, hey, if we, before the provider sends that prescription to the pharmacy, right, can we see whether that's available or not? So at least the patient knows, hey, don't go right away, maybe wait a couple hours. And it's things like that. Like we had a lot of new organizations that had never really been involved in the standards development that came to the table to say, hey, this is an important thing that we've been hearing from our customers. Let's figure out how to solve it. And it's important because what came out of that was you have your traditional pharmacies where, you have a location, you're able to send that. But what about Amazon pharmacy, right? Where it's now being delivered? Well, and I'm going to get a little more technical here, but you need zip codes versus, a location. So things like that, if folks hadn't been at the table to talk about it, we would have gone down and built a standard in a certain way. And then everyone would come and be like, hey, that's not working for us. So I think that's really, really important for people to come to the table. Just real quickly, one thing now that we're doing at NCPDP, since we don't really do the kind of connectathon way of doing standards, we've introduced a new concept called collab. And the day before our work group meetings, we are opening it up to members and non-members to have more of kind of general conversation. So we have roundtable discussions where people can talk about workflow. They can talk about a standard that maybe it's not working for them and start having those conversations. So even if you're not a member of NCPDP, you're thinking about implementing a standard or you have a new idea for a standard, that's where those really early conversations are going to be happening now for people to be able to start having those conversations, whether you're a provider, whether you're a vendor, whether you're a payer, to say, hey, this is a problem I want to solve. How do we do that? And I think that's going to now give people another opportunity to come to the table a little bit early before we start actually developing standards. So that's kind of how we're approaching it at NCPDP. So
that's exciting. Anna, I know you guys bring together industry leaders to solve problems as well. What's your take on all this?
Yeah, I think not being involved is probably your least rate of return. The amount it costs to participate in these communities and the return on investment that you get within your operational models and your economic models when it comes to healthcare is immense. And we've been doing the math at MultiCare, and it makes a lot of sense to install the capability of prior authorization for, I don't know, like the cost of $8,000 in labor, and then have this, if you have 100 people who are doing OS, I'm being illustrative, but 100 people, and maybe I'm not being illustrative, but that do OS in your organization, and that can be sped up. Their productivity can ×3 or ×4 because of this capability, and you make it work because you've been at the table identifying how it's going to work for your organization. It's immensely powerful. For under, $100,000, I just got $1 million return. So it's really important to participate in these conversations, not only because we all need to ensure our economic models work, but it also needs to work for all the lenses like Pooja shared. If Amazon wasn't at the table, then we wouldn't have considered zip codes for something important in that payload. So we need all the lenses to be able to ensure that standard or that agreement, how we're going to participate, rules of engagement, I call them, happen and get executed. And if we have something that's not a utility, it's not going to work. We can't recycle, we can't reuse. And I think another thing, if we're thinking future, because my head is always, 30 years, 10 years, so I'm thinking that way. These are the foundational trades, data trades that are going to predict, that AI will use in order for its data model to predict whatever it needs to do, or its agent to act. So thinking that way when we're at the table and having people who think that way at the table really, really matters. And the earlier we have those conversations, the better the outcomes are going to be for our patients and our members and humankind in general here in the US. So it's important to get involved. I think when you're not involved, you're missing out on a very valuable conversation, because not only does it bring productivity and cost avoidance, but it also brings new knowledge, new ways to see a problem into your organization. And you start really enveloping that high reliability organization that we're all striving to be in the marketplace. And you start to think differently about everything you're trying to solve. And then that kind of catches on as a culture, and people start having this mentality where they ask hard questions, and they can ask hard questions, and they can fail fast. And then, it just moves everyone and matures everyone forward. And for this very small investment, you're getting this huge return. And I do think people need to participate early, because, like I said, these are going to be foundational trades to the future of how agents work, how data is analyzed, and how we enable that data to follow the patient throughout its entire lifespan of health.
I couldn't agree more, Anna, and well said. The only thing I might challenge you on is the 30 years. I think AI and agents is going to be upon us much sooner than that.
Yeah, singularity is coming in 3 years. So get ready, everybody. Machines are going to train machines. And if these data models aren't right, they're going to be training on the wrong thing. So this is so important. And I agree with you, Tony. It's not going to be 30 years. But I can imagine someday I'm going to lay on some sort of thing, and it's just going to analyze me and say, oh, you need to do this and this and that. And then the provider will cross-check it, and we'll be good to go. It's going to be awesome. That's coming sooner than later.
Kind of like Star Trek, right?
Yeah, little bit.
Okay, CMS 0062P directly references both NCPDP and the HL7 Da Vinci standards and implementation guides. Talk a little bit about how CMS determines which standards to designate as required versus recommended. Anna, let's start with you this time.
Yeah. Okay. So a part of the process, as Pooja described, is we have ONC, CMS, the National Standards Group, High IG, all of those groups are at the table having these conversations with us in Da Vinci in order to ensure that what we're doing is implementable. Because we can try these things and, it's not going to work because the certification isn't good enough. Bulk doesn't work, which we all know bulk doesn't work. But we're going to get better because we're going to solve for the certification gap that's happening in there. So having the whole process of determining what is required and not required is looking at something from a systematic view and ensuring that all the pieces that have to make it mature and give it that credibility come together. And so ones that get required are standards that can lock right into the system. And what the work we've done with prior authorization and burden reduction is we went out, we got the waiver, we participated in the waiver, we wrote our research project on that, we wrote our paper, we said, yes, it works, here are the results that are happening when it works. And that gives us a proof of concept to say, all right, this probably needs to be locked into some of the rules and regulations. And those are the ones that get designated, ones that have been tested in the industry, ones that have proven it with science that it works. And the standards that get designated versus required are ones that maybe don't need, we can self-regulate with. I'm thinking about ATR. And ATR is like a list of people in general. Like that's how to trade a list of people, which we all trade lists of people for many reasons in many industries. And that standard itself isn't something that's required. It's designated, it's recommended, because that one self-governs. It doesn't have to have that happen. But when we think about prior authorization, there's a lot in the market. There's a lot of dynamics in the marketplace that make it challenging for us not to make that required, and proving that the science works and that it is going to make, our ability to monitor fraud, waste, and abuse better. It's going to improve our ability to enable patients to get answers faster, to bring payment faster. All of that is a better, not a worse. And so when others don't want to come along, that's when it gets regulated, it gets required, especially when it's already been proven. So I think the maturity of these use cases when we test and then implement and then share and then science and the circle of life as that goes, I think it's how that gets determined as to required versus designated. And I think that goes to show that it's very important for everyone to be involved in that conversation. And as we think about this as a footprint for healthcare in the future, we don't want a lot of things to be required. We want them to be designated so that we can self-regulate those things. And so the more we have involvement where we can prove self-regulation, the better this is going to be for the industry. So that is a whole nother reason for people to be involved in the conversation, is if you want to either be told what to do or be a part of the solution and figure out what to do.
Well said, Anna. Pooja, what's your take? How does CMS determine which standards to designate as required versus recommended in the pharmacy side of healthcare?
Yeah, I'll talk about that in a sec, but I want to go back to something that Anna said, right, about the whole exception process. I think it's really important to recognize that CMS, other HHS agencies, they're watching, right? They're listening, they're getting feedback. And I'll go back to my point of care partners days, actually. I mean, CMS used to reach out to us and be like, hey, what's really happening, right, with this standard, or what's happening in industry? And I think that's really important to your question, Tony, is like, how are, they're not just going to name something, right, that people aren't using or that's not working. They read every single comment that's made on a proposed rule, right? And they take that to heart. And I think that's really important to recognize. I think as far as the proposed rule goes and NCPDP standard, our standard's been around almost a decade. Tony, I know you were very involved with the early days of this, and there was a lot of kind of testing and all that, but we were named for Part D. So, the NCPDP script standard for prior auth has been around for a long time, and it's been named, but now they're trying to expand that, right, to other health plans and other, coverages. But I think it's also something to recognize that, even though we've been named, we've been in workflow, transactions are actually flowing today. What CMS has been doing with us is saying, how do we get more of that adoption, right? And so, even with the name standard, it's not that you just name it and you move on, right? There's this recognition that maybe the adoption isn't where we needed it to be. Maybe the implementations are not right. So I think the conversations we're having now with our standard is, how do we get the stakeholders together to say, it's been out there, but maybe it's not being used the way we want it to be used. So, I view it as organizations, first of all, should not ignore it because, whether it's regulated or not, to Anna's point earlier, right? We want it to be designated. We want people to use it. We want it to make it easier. And I think, kind of the other thing that I think is if you look directionally, and I think we saw this, back in 2020, 2021, when we started to see CMS and ONC really working closely together with the regulations. The way I look at it, HTI-4 came out saying EHRs now have to get certified, right, for NCPDP's script standard for EPA real-time benefit check, right? Now, all of a sudden you see this proposed rule. So people need to kind of look at, I would say, the tea leaves, right? Of like directionally, which way are we going, right? If you just ignore it, like if you ignore all the signals that are coming out, you're going to be behind and you're going to be frustrated and you're not going to be able to keep up with what's happening. And I think that's another kind of important note for the listeners is pay attention to, both what ONC and CMS are saying and their proposed rules, because they're really starting to work more hand in hand now, I think, than we've seen, in the past. So.
And in both HL7 and NCPDP. I mean, it used to be that they would show up in droves at HL7, but not as much at NCPDP. Now you go to both, and they're all over both meetings. It's really exciting and encouraging. Medical and pharmacy benefits have historically operated with different workflows, standards, operational assumptions, and data structures. As the industry moves towards a more connected experience, what opportunities and challenges stand out to each of you? Pooja, let's start with you first this time.
Yeah, this is a big one. I think we've always said, right, on the pharmacy side, like we've had real-time transactions for a long time, but you can't just look at the pharmacy transactions in a silo anymore, right? You've got to step back, and I mentioned this earlier, right, and look at workflow. So as a provider, I think this is kind of one of my soapboxes is a provider's not going to see all the medications that are covered, right, when they go to prescribe something, because some are covered under the pharmacy benefit, some are covered in the medical benefit, as you said. I think what's interesting about this proposed rule is there's some questions in there, right, of like, how are we going to do this? How are we going to allow the provider to know that, hey, I want to prescribe this medication. I don't care whether it's under medical or pharmacy. I just want to prescribe it. I want to get the prior authorization done. I want to know how much it's going to cost out of pocket. And I just want my patient to get on it. And so I think there's a lot of kind of workflow considerations as part of this. I've seen a lot of different takes of, is it going to be FHIR? Is it going to be NCPDP? And I think it's clearer that it's going to be both, right? But then how do we work together? How do we get the honestly, the EHR vendors to say, it's not going to matter in the back end, but how do we show everything to the provider? And I think it's all of us, right? It's EHR vendors, it's the providers, it's the, the technology vendors, it's the payers of saying, we have to be thinking more about workflow as opposed to specific standards. And I think this is, to me, the first proposed rule where we're having to tackle that. And I know there's a lot of work that's being done. in Massachusetts, right? They're starting to look at how are we going to do this. I know there's other work being done in other areas of saying, hey, we've got to figure this out and working together. Because honestly, in the end, the providers and the patients don't care where it's coming, right? They just want to get on their therapy. So I think as an industry, we need to zoom back. We need to look at it from a workflow standpoint, not just a standards standpoint. And we need to make sure that upfront, everyone has all the information they need of what's covered, how much it's going to cost, all of that transparency. I mean, really, that's how we're starting to think about it and starting to have conversations about it. I think that's a big thing that we're going to have to tackle with this specific rule. So, yeah.
To be sure, I don't know any patient that could say whether something's covered under a medical benefit or a pharmacy benefit.
We all talk about it. We all talk about it every day.
Answer that.
Yeah.
They don't even know that that's something.
I know. They don't even know what that is.
Yeah. Nor do they care.
Nor do they care.
Yeah.
Anna, what's your take on this workflow thing?
Yeah. I mean, as a human factors engineer, this is at the deep corners of my heart, because whenever I work with a group trying to implement, improve something, create technology that enables, I do not want to start with the technology. I want to start with, how do you want to work? What is that you're wanting to do? And whether it be from a patient perspective, provider or payer, we reverse engineer from there, because the way technology has grown up in healthcare has more been, hey, healthcare, we're your IT department, and we're going to tell you how you work and what you do. And that is actually a maturity curve of technology adoption in general. Like, yes, okay, somebody has this idea, it gets adopted, people are always, oh my gosh, you're the expert, we just look to you. And then the knowledge becomes a commodity. Like, everybody knows it. It's a utility in the world. And now people can code their own intelligence agent to identify the lung cancer in the data and in the lab results. So it's something that, as we move forward and mature in our healthcare capabilities and our ability to live lives longer without chronic disease, we are going to have to not look at the technology and ask it to solve these point solutions, but we're going to have to look at what we want to achieve and reverse engineer from there, because the technology is there. It's capable. It's affordable too. It used to not be affordable for healthcare. So we can now rethink. This is a transformational time. My husband and I were like, is this a revolution, an evolution? What is this? What is this? And we settled on evolution, because it's really healthcare maturing into this new era, and we may just have to rethink everything. But that's not from a scary perspective. What it means is that if I need a cancer drug, and part of it is medical and part of it is pharmacy benefit, then behind the scenes, those things need to happen. As a provider, I don't care how you get it done. Like, the technology needs to be mature enough and smart enough to be able to give me what I need. Okay, you have these 3 choices. It's going to cost this much. If you want this one, you have to take these prior authorization steps. If you want it covered under pharmacy benefit, these are the other drugs you have to try before you get there. There needs to be, that's how the provider wants to work. Like, okay, how do I guide my patient through this journey? And they need that information to do it. And we should be just looking at that as a reverse engineer to the future. And I think Pooja is saying that all of this just needs to happen. And the standard has been around for 10 years. That's fantastic. It's very mature in getting the data you need to accomplish this. And now we need to think about, how can we use modern technology to achieve what this has always wanted to achieve, because that hasn't been available to us. A lot of the data and the models have existed in unstructured spaces or UI data that's analyzing and saying, yes, in the UI, but it doesn't store in the master database. So there's lots of things that we have to solve for in order to get all these workflows to come together. But it is the thing we need to do in order to get to the place where you thought healthcare always was. Like when I got to healthcare, I'm like, what? What are you talking about? Isn't this how it works? No, it's not how it works. So I think there's a lot of opportunity. And I think prior authorization burden reduction can help bring these two things together as a place and a means to eliminate that fragmentation that we see today, and like, this is my process, this is your process. No, the process is the provider needs to do the journey with the patient. Now, how do we both get them what they need to be successful? And let me tell you, if I'm a healthcare vendor, that's going to sell my product, and I won't even have to do marketing to do it, because people will just adopt it. It's like ambient technology with scribing. Okay, there's no education team, there's no nothing, like providers just turn it on and they want to use it. Now that is a winner in a human factors heart, because it should just be this organic, humanized workflow that they don't have to think about adopting. Think about all those things on your phone that you don't have to think about learning. I can easily buy something on Amazon or Stitch Fix or whatever company, because they make it easy, they make it human. And I think healthcare has the same opportunity to do that.
I love that your pillow talk is revolution versus evolution. I love that.
We couldn't decide. We're like, nah, it's not really a revolution.
Now we know the secret of your success. You guys have, really cogent conversations at home.
Yes, deep conversations about life.
About life. Well, one theme that continues to surface is that interoperability is no longer just about moving data. This is your point, right? It's about delivering the right information in the right workflow at the right moment. What are some of the biggest challenges the industry still needs to solve to make providers actually trust and use these workflows consistently? Anna, let's go with you first.
Yeah, it's a really deep whole other podcast for me in my mind. I think, Pooja, I've heard you use the word trust a lot, and you're talking about getting 200 people in a room so that you can have real world adoption of the NCPDP standards. And that's really about what it is. It's delivering the same consistent information every single time to build trust. If we go back to who wrote that book, Covey, is it Trust? What is it? Speed of Trust. Who wrote Speed of Trust? I can't remember. That book is like extend trust wisely. So, you just one chip at a time, one token at a time, we're going to give the right answer. And then that right answer is going to add up to 1,000 right answers, and then adoption. And that's how we get momentum when we think about creating these new workflows and new capabilities in healthcare. And one thing that's been really challenging, especially in quality, is been the way we measure quality has been at sample size. And if you took statistics, which I did, and it was my 830 class several years in a row, but I still got a good grade, thanks. It is, once you go bigger, your error rate can get bigger, right? And when you first start something, you're like, oh gosh, it's really wrong. But oh wait, and the data is not quite right. We're going to make it better. And you get to this same error rate as you would see in the sample size. And right now, that industry in general, every vendor, everyone who works in that industry is used to working with sample sizes. And we're about to make an evolution for them to be able to measure quality at scale. And we have other implementation guides that are associated with quality. We have DEQM and Da Vinci, and we're working on how does this work in the big picture of quality. But all that data quality, FHIR hasn't been mapped before. They've done it once in their testing, but every EMR instance is different. And so there is going to be this period of time where it's not going to look like sample size. It's going to look like you're doing really bad because the data isn't mapped, or it's stuck in the UI, or it doesn't exist yet, or somebody's clicking the wrong button. Like, there's so many reasons why data isn't where it should be. And none of that has been curated. Whereas we have like 20 years, I don't know, 20 years, I think, of curated quality data and how we get there. So I do think that adopting these APIs in a standard way enables us to have a standard ontology for healthcare, which is the data model, so that we can expect data to be where it is. And we are going to have to spend, 2 or 3 years here in industry trying to map those to the right places. A million times I've tried to get around the mapping problem. I've asked some really smart people, like, how do we leapfrog over this mapping problem? And there isn't a way. The only thing you can do is speed it up with an agent or something. But you still have to map the data correctly. And who knows, maybe when we reach singularity and the bots are training the bots, we might get someplace, but we're not there yet. So we still have to do all this mapping. And as soon as we can get that data to a place where it's, I would say a good error rate is, today they're working with about a 75% error rate. So if we can get to 75, which we shouldn't be, we can get to 97 if we want to. But if we can get there, we might see and earn that trust. We might get that, reduce the amount of work that a provider has to do, so reduce burden. And I do think that this new rule 0062 is going to enable us to do that, because it's requiring that we use the standard ontology. And yeah, we got some mapping to do, so expect that and be ready for that. But that mapping is only done once, and then you recycle it for many, 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 many uses, not just this one.
So Pooja, I'm dying to know if you and Bobby also have discussions about evolution versus revolution. And also, what's your take on some of the biggest challenges the industry still needs to solve to make providers actually trust and use these workflows consistently?
Yeah, we actually do. We have a lot of these conversations as well. He's on the education technology side, but yeah, a lot of the conversations. But I guess for me, I do talk about trust a lot. But like, to me, the scalability is so important. And I think when I think about, like, on the pharmacy side, and obviously prior authorization is important, but I'm going to talk about price transparency. And I will say that, again, we've had a standard out there for a long time for pharmacy price transparency, but the adoption of it, I think, stalled, because what was happening is the providers would go to click on the button that they saw that said, check the price of the prescription you're about to write. And it would come back with, price not found or no information. And part of it is because we didn't roll it out fully, right? We've done these pockets of roll it out for Medicare, or, Part D, roll it out for this. And I think we have one shot, to me, with the providers to build that trust, that if I push this button, I'm going to get the information back that I want and need. And if you do that 3 or 4 times and it's not the same information, or you get it for some patients and you don't, you're going to lose that trust. And so I think we also need to be thinking about how do we actually roll this new technology out and these standards out to make sure that we are building that trust with the people that are using it. And I will say, super eye-opening. I've been in this industry and working with real-time benefit check for, 8-9 years now. I was at a listening session 2 weeks ago at HHS, and I heard someone say that, yes, we get the information back, but we don't show it to the provider because it's just noise, for the real-time benefit check. And I just sat there like, oh my gosh, like, we have, first of all, you have HHS out there saying, this is technology is available. Make sure you're, clicking on it, doctors. And then on the other hand, we have people that are saying, we filter it out because it's noise. And, me as a standards development person was like, wait a minute, and then you have the payer saying, we're sending this back to you. What do you mean you're filtering it out? So I think we need to, again, take our biases out and say, if I'm a provider, right? And Anna, you said this earlier, right? Like, I don't care. I just want to make sure that my patient is getting the treatment they need. They're able to afford it, all of that. If we're filtering and we're not applying it across the board and we're not, building that trust with that provider, that data is accurate and available for all my patients, you've lost people right away. So like when I think about trust, like that has really bothered me, obviously, for the past couple of weeks, right? Like it just is like, how are we going to get past this if we are not giving the information at the right time and allowing providers to trust that when they push that button, they're actually going to get information back and the right information. And I think that's a huge problem that we need to think about solving now, which wasn't on my to-do list, but now is. So anyways, that's how I think about trust is, how are you going to get the provider to, or even the patient to trust the information, which is a big deal.
So my wife, Andrea, doesn't have a health IT background. So when we talk about trust, we talk about it in a little different way. And by the way, when we think it's evolution, Anna, not revolution, but
yeah.
But nonetheless, as organizations review CMS 0062P and consider submitting comments, where do you believe the industry should focus its feedback beyond simply supporting or opposing the timelines and requirements? Pooja, let's go with you first, please.
Yeah, I think it goes back to the conversation we were having about workflows, right? Like, obviously people are going to comment on the timelines, all of that, but there's some really good nuggets, I think, in this. And I guess when I think about it, one of the pieces that I think people should pay attention to are the RFIs in there, right? There were a lot of really good questions. One of them in particular about care coordination, which again is something that we're talking about, right? Like ADT notifications. I'm just going to bring that one up because, as NCPDP, we put out a white paper about, maybe ADT notifications should be going to the pharmacist, right? Like, how are we thinking about other things? So I think we do focus so much on like, oh, we can't meet this timeline or, things like that. But this is a big proposed rule. There is a lot of really juicy nuggets. There's some great RFIs in there. I would tell people to really think about, like, beyond the timelines, what else is in there that we need to be thinking about? Like we said, directionally, that obviously CMS is thinking about, because that's going to be what's next. And I think that's really important to pay attention to. So
yeah, this is the strategy. It's almost a strategic RFI where they're looking to set the map for the rest of the time. And it'll be really important that everybody comes with the lens of, this is how I want to work. Not, I can't get this isn't feasible, I can't get this done. Removing those constraints and thinking from the mindset of, how do I actually want to work? And if I want to work that way, how long do I really think that's going to take to engineer all that? That's the kind of answer that they're going to pay the most attention to, I think, is, I want to work this way. And the reason I want to work with this way is because it's going to improve outcomes, reduce fraud, waste, and abuse. There, we wrote your paper for you. You can leave a comment. And I think it's really important that people participate in that, because yes, these are really aggressive timelines, and our infrastructure today, even the ones that are behind, it's absolutely possible with today's capabilities to do this faster than you think. Maybe not within the timeline. Maybe we do need to push it slightly. But we can get this done faster than you think if we're taking that perspective of not holding on to a kingdom. Like, I'm doing this because I want to work faster. And when we all do that, everybody wins in the growth, in the economic growth. And you begin to not leave anyone out in that situation. But when we start to hold on to something that we don't want to evolve, then that just holds us back in our maturity to be able to advance our growth and our economic growth. Healthcare, maturity growth, and economic growth. Those are all related things. And you can say they're not, but they are. It's proven. People go to work when they're not sick or they're taken care of. So I think it's an investment that not only payers, providers, and pharmacists and should be making comments with, but also companies, employers. patients themselves need to be commenting on this rules, because it's going to matter how you get to see what your bottom line is in your healthcare and what you're offering. TPA services, they don't do this stuff. They do minimum necessary, and they're not regulated, self-funded, not regulated like we are. And here we are opening up all these capabilities to measure success and really dial in on your managing your pharmacy benefit, which is probably the easiest way to manage a medical loss ratio, is to focus on pharmacy these days. And if we have that data and information to make the right decision at the point of care on the lowest cost drug with the best outcome for this patient, all those things are possible today. We just decide not to do it. It's going to change everybody's bottom line, growth, economic growth, health, maturity growth, all of that. And we got to do it for the good of everyone, including that incentive to be able to grow companies and create new jobs because of it.
It's really important. And, another thing you said I want to expound on, which is you talked about how fast, what the pace of all this and how fast it needs to be implemented. And that goes back to something we've been talking about through this whole podcast, which is why it's so important that you get involved as the standards are being developed, in the work groups at Da Vinci or other accelerators at NCPDP and the different work groups and task groups. Because once it gets out there and gets into regulations, yes, you have a chance to comment on it, but then you're going to have to implement. And the sort of days of delaying are behind us. And so it's really important that you get involved, as if we haven't said that already. We always like to close with this question. If you could encourage healthcare stakeholders to think differently about one thing or start doing one thing differently tomorrow to help move interoperability, policy, and patient experience forward in a meaningful way, what would it be? Pooja, let's start with you first, please.
Yeah, I think from my perspective, one thing we've been talking about a lot at NCPDP is really the changing role of the pharmacist, right? Like we've always viewed pharmacists as dispensing medications, but we need to expand that thinking of the role that they can play in care coordination. We're even talking about the role that they can play in prior authorization. Why aren't pharmacists, joining QHINs and, under the operations SOP, being able to pull information to help a prior authorization move faster? There's just a lot of things that we need to be thinking about because, Anna just mentioned this, right? Like focus on the pharmacy benefit. If you get your patient on the drug quickly, like you can save so much money. You could save on hospitalization, on ER visits. And, we have to look at it holistically, right? And I think that is so important. And part of that is recognizing that a pharmacist can help with that care coordination. They can help with getting that patient on the drug. They can identify, hey, this interaction, like I got to get back to the provider to make sure, they're changing the therapy based on something I know as a pharmacist. So, ideally you're looking at it as, kind of holistically of, my goal is to get this patient on treatment, whatever that treatment is, improving the outcomes. And how do we all, as different lenses, looking at it as bringing everyone together? We mentioned it already, getting the right information at the right time to the right caregiver, right? Whether that's the patient, the provider, the patient's caregiver, the pharmacist, the nurse, like whoever it is, just making sure that that information is flowing and all of the information is available that they need right then. So I think that's kind of the way I would be thinking about it.
How about you, Anna? What's your take on this one?
My call to action is to get involved in the conversation. I think what's been driving us forward are people who have that spark, who really have a passion for, like, I'm going to change this and I'm going to tell you what I need and be at the table for the conversation instead of complaining about what's wrong. They're at the table talking about what they need to make it better. And when we sit in these Da Vinci calls, by the way, which are all public, so you don't need $1 to participate in these things. They just need your smart brain at the table. You can be a patient. You could be an employer. You could be anyone sitting at that table and saying, this doesn't work for me. I need it to work this way, as the vendors and the payers and the providers are all hashing out the details around the technology. We need those end users, the experience, to be immensely influenced by you. Like, come to the table. That's my call to action, is to get those employers, to get those patients at the table, also saying what you need in this. There's always been an open invite to this work. And I think it's important to get involved, because we will build the thing that works if everyone is at the table. And we're not saying no one can come. So come participate in Da Vinci, come get involved in our use cases. And so that we can make these as best as they can be, as utilitarian as they can be for everyone to use, so that we can stop talking about the stuff that we don't want to talk about. Interoperability. I know Pooja doesn't want to do that. She wants to talk about getting the drug to the patient and making sure the pharmacist is empowered to be involved in the conversation with the provider. I mean, I can think about blood pressure control as such like a dialing in of things, and having that a real-time conversation electronically, it could actually happen that way, would be so powerful. And then the patient could understand, oh yeah, this is all about chemistry, right? And, you know, like, why don't I have to go in? Why do they just titrate it? Okay, well, it's because that's what it's about. It's about getting you to your right little, you know, milligram. I don't know what it's prescribed in. I can't remember, but it's important to have everyone involved. So my call to action is to get involved, be a voice, and don't think you don't count, because everyone has a healthcare experience.
Absolutely. Pooja, Anna, thank you both for joining us for sharing your perspectives on where interoperability standards development and policy are headed next, and giving us a little insight into your respective marriages. One of the biggest takeaways from today's conversation is that the standards communities are not just technical work groups. They're collaborative environments where operational challenges get surfaced, tested, debated, and refined long before they become federal requirements. For organizations trying to understand where healthcare interoperability is headed, participating in those conversations matter. For our listeners, you can find this and other episodes of the Dish on Health IT wherever you get your podcasts. If you enjoyed this discussion, share it with a colleague and subscribe so you never miss an episode. And if this conversation raised questions about how proposed changes in policy and standards may impact your organization, reach out to us at Contact Us page on our website, which is POCP.com. So until next time, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with FHIR accelerators? Email us at interopoutlook@POCP.com to learn more about our Interoperability Outlook subscription monitoring service.